In this video, we will review glaucoma as a cause of chronic vision loss. We will discuss how glaucoma is defined and categorized. We will discuss risk factors for glaucoma, as well as physical exam findings and ancillary tests that can help diagnose and follow glaucoma. We will also discuss medical and surgical treatments for glaucoma. Glaucoma is a group of diseases that damage the optic nerve with characteristic optic nerve head and visual field changes. Elevated intraocular pressure is often present, but not necessary for the diagnosis, as in normal tension glaucoma. Glaucoma can be classified by whether the anterior chamber angle is open or closed. Normally, the ciliary body produces aqueous humor which flows around the lens, through the pupil, and exits the anterior chamber angle through the trabecular meshwork and Schlemm's canal, with a minor component of outflow through the uveoscleral pathway. In open-angle glaucoma, there is increased resistance to aqueous outflow at the level of the trabecular meshwork, which results in increased intraocular pressure. Open-angle glaucoma is the most common type of glaucoma and is often associated with chronic vision loss. This should be differentiated from angle closure glaucoma, where there is apposition of the peripheral iris to the trabecular meshwork, blocking aqueous outflow. In the acute form of angle closure glaucoma, this can lead to a sudden increase in IOP, accompanied by eye pain, redness, seeing halos around lights, and nausea or vomiting. For the rest of this discussion, we will focus on open-angle glaucoma. More than 2 million Americans have glaucoma, and it is one of the leading causes of blindness in both the U.S. and the world. Elevated intraocular pressure is the #1 risk factor for glaucoma, and is important because it can be modified. Age is another important factor. In Americans over 40 years old, glaucoma has a prevalence of around 1.9%, and this significantly increases with advanced age. Glaucoma is 3 to 4 times more prevalent among African Americans than Caucasians, and is the #1 cause of non-reversible blindness among African Americans. A positive family history and decreased corneal thickness are also risk factors. Diagnosis of glaucoma can be made by physical exam and ancillary testing. Intraocular pressure is most commonly measured with the Goldmann applanation tonometer. Normal pressure is considered to be between 10 and 21 millimeters of mercury. The higher the eye pressure, the higher the risk of glaucoma. The optic nerve can show signs of glaucoma in a number of ways. Most commonly, there is diffuse enlargement of the cup, the central depression in the optic disc. There can also be notching, which is focal enlargement of the cup, as seen inferiorly in the center image. Nerve fiber layer hemorrhages can also be present. This is more commonly seen in normal tension glaucoma and can be a sign of progressive disease. Gonioscopy is an examination technique that uses a special lens to visualize the structures of the anterior chamber angle. This can determine whether the angle is open or closed, and can also be used to detect signs of secondary glaucomas, which are glaucomas associated with other ocular or systemic disorders, such as pigment dispersion syndrome or angle recession from trauma. Humphrey visual field testing is helpful for both diagnosis of glaucoma as well as monitoring for progression. Some patterns of visual field loss that are commonly seen in glaucoma include a nasal step, paracentral scotoma, and arcuate scotoma. Because peripheral vision is often affected first in glaucoma, many patients are asymptomatic until the disease is very advanced, when central vision can be affected. Retinal nerve fiber layer thickness is another helpful ancillary test in the diagnosis and management of glaucoma. The optic nerve consists of around 1.5 million axons of retinal ganglion cells, whose cell bodies lie in the ganglion cell layer of the retina. The axons of the ganglion cells course through the nerve fiber layer toward the optic nerve. The nerve fiber layer can be measured quantitatively, and thinning of this layer suggests glaucomatous nerve damage. Treatment of open-angle glaucoma falls into 2 categories, medical and surgical. Medical treatment decreases intraocular pressure by either decreasing aqueous production or increasing aqueous outflow. Beta blockers and carbonic anhydrase inhibitors decrease production of aqueous fluid. Prostaglandin analogs and rho kinase inhibitors increase aqueous outflow. Alpha-2 agonists do both. Surgical techniques are commonly used when medical therapy fails or as an adjunct treatment. These procedures work to facilitate outflow or provide alternate drainage routes for aqueous humor. Laser trabeculoplasty can be performed in the office, while trabeculectomy, aqueous shunt implantation, and minimally invasive glaucoma surgeries are performed in the operating room. Progression of glaucoma can be highly variable from person to person. If intraocular pressure is not controlled, progressive visual field loss can occur, often starting peripherally and in more advanced stages affecting central vision also. Once vision loss does occur, it is irreversible. Fortunately, this can frequently be prevented with early diagnosis and treatment. All images are from the American Academy of Ophthalmology's multimedia website, and content was derived from the AAO's BCSC glaucoma book. Thank you for watching.